Are we on, Pete? Thank you all for being here, first and foremost, and thank you for the work that you do, especially those of you who are clinicians. One of the reasons that the nation, hospices in the nation, are jealous or envious of this valley is because of Carolyn Nystrom. You've had her, you have her. Those of you who work for her or who have worked with her know that she is a force of nature. And I'm privileged to count her as a friend as well as a colleague. I'm really privileged to be here. I'm not an expert either, although I was thinking when she was talking about that the word expert is sometimes broken down into its roots, X meaning an unknown quantity and spurt meaning a drip under pressure. In that case, for many of you, I am that person. But what she said is true. In a sense, there's none of us who are experts in this. Those of us who are clinicians in hospice and palliative care become expert one person, one patient, one family at a time. Because as I hope to reflect on, the care of people is so particular that you can't get it from best practice guidelines or algorithms alone. You really have to dig down into the person of the people you're caring for. My main credential, I think, is that I'm a practicing physician. I struggle with all of the issues that I'm about to overview day in and day out. This is hard. It's hard to be giving the best care in the current circumstances. But in addition to being a practicing physician, I'm a son, a son-in-law, a brother, a husband, a father, now a grandfather. And that really is who I identify myself as. So I speak to you in fellowship, really in honesty. We have a lot of work to do together as a field, but also as a community, as a caring society. And that's why I'm here, because we have to have a conversation. There is a lot to do. I mean, we live in unprecedented times, right? We're an aging population. For the first time on the planet, there are about to be more old people than young people. We've turned the Malthusian pyramid, that we were all taught, upside down. This is unprecedented in human history. It's a good thing because partly we're living longer. And that's partly because of the miracles of modern medicine. Right? Because in addition to the silver tsunami, the other major demographic trend is that we invented chronic illness. Chronic illness is an invention of the latter part of the 20th century. People used to die quickly of all the things that we now can expect to live with for quite a while. Congestive heart failure used to be a sudden diagnosis, sudden death. Got pulmonary edema, you were gone. Nowadays, I used to practice emergency medicine, it's a bump in the road. Even if you needed to be intubated because of flash pulmonary edema, you were likely to be out at home again in just a few days. End-stage renal disease obviously was a terminal diagnosis before dialysis. And now transplants and the like. These are great things. I'm so glad we have them. Cancer care has gotten incredibly much better than it was when I was growing up. Now we're curing about 60% of solid tumors. And those we can't cure, people can live with often for many, many months. And for most of that time, quite well. Now, all of this is great. The problem is, of course, we've yet to make one person on the planet immortal. That means that at some point in time, if we believe that more disease treatment is better care, it's like pushing against an immovable object with the person of the patient in between. Somebody's going to feel the pressure and get squished. In fact, we've made it harder to die than ever before in human history. Not intentionally, of course. Unintentionally, because we love life, And while we in hospice and palliative care have been promoting this notion of people being comfortable, their dignity honored, and allowing them to die well, there have been countervailing trends in the therapeutics of disease, even late-stage disease treatments these days are getting pretty good. LVADs for congestive heart failure, some of the IMAB, you know, the tailored drugs, immunologically tailored drugs for cancer care are getting pretty good. There are things you want to consider if you or a loved one is dying. And what I've learned, by the way, is the main countervailing force is that people still don't want to be dead. And for most part, their families don't want them to die either. And we doctors come to know our patients as persons. We get attached to them. It's not uncommon, and this is a secret within our profession, but many times we come to love the people who are our patients. We don't want them to die, and we have all of this technological armamentarium to bring to bear to fight disease. So we have unprecedented challenges. Nobody's at fault, but that doesn't mean there's not a serious problem that we all need to figure out. It's becoming harder to die in the country. People are sicker before they die. And, of course, we have a problem of having fewer family caregivers in our latent networks of family and friends. Just look at what's happening here. It's fallen from, you know, early, when I was growing up, 11 to 1, you know, ill person to latent caregivers in their cluster of adults who might be able to provide care, and it's fallen progressively. Look, it's gonna get down to what? Less than 3 to 1. By the mid-portion of this century. You got to hope that these people like lattes. There's still not enough Starbucks because they have a lot of work to do. Now, in addition to that, of course, the costs of caregiving have become outrageous. Why is that? It's particularly bad in this country. Here we are. Stephen Brill, in March of 2013, published this remarkable article called The Bitter Pill. And he asked the question, well, he said, well, everybody else is asking, how can we possibly pay for health care? One of the questions we should be asking is, why does health care cost so darn much? And he digs down into the reasons. And what he says, and he does so in a very journalistically careful way, but what you get from this is that while you and I are striving for and working toward a truly patient-centered healthcare system, I would say a truly person-centered healthcare system, what we have in America is a profit-centered disease detection and treatment system. And it's not entirely a bad thing, because it does a heck of a good job of finding and treating disease. But it's certainly not the whole thing. And if you want to figure out how healthcare is organized, follow the money. So there are people making huge amounts of money, while many of Americans are going bankrupt because of healthcare bills. Even if you think that at, 18% of our gross domestic product, healthcare is worth it, and certainly there's, some reason to believe that. We're clearly at the top of the heap in terms of costs. And one could argue, I think persuasively, that we're not getting an adequate return on our investment. I mean, if it was worth 18% of the GDP and so much more than these other developed countries, you would want to feel like we were, getting absolutely Cadillac care, maybe Lamborghini care, right? But we're not. We're simply getting more expensive care than anybody else on the planet. Why do things like colonoscopies cost so much more here than elsewhere? Why do things like, the statins that we take, even our antibiotics, cost so much more here? There's an article in this week's New England Journal about the use of colchicine for pericarditis, but colchicine has been used for, generations to treat gout. It's suddenly become an expensive drug. It's like dirt cheap. This is not right. Something is wrong. And I'm an ardent capitalist. I love capitalism. I think it's great. But something's unbalanced here. At some point, even a good idea becomes excessive. We know that if you follow the dollars, that there is a mismatch between the intensity and money that goes into care through the end of life and the quality that comes out. This is an old slide, but it's still worth showing because it comes from now, 2 decades of work by Jack Wenberg and Elliot Fisher and David Goodman and other colleagues of mine at the Dartmouth Institute, right across the street from where I've worked at Dartmouth Hitchcock. And they've looked at variations in healthcare dollars. And in this study, they looked at the recognized best medical centers in the country. And they found that even at the acknowledged best, there was a twofold difference in the amount of dollars spent during the last 2 years of life, which relates directly to the amount of doctors you see, days in the ICU, days in the hospital, procedures, et cetera, with really no relation to quality. Actually, that's not right. When you actually look at things that people value, time at home, whether people were comfortable, whether they had a chance to talk about things, it turns out that where there is the most healthcare dollars tends to be the lower quality. Not utterly consistently, but the trend is really there. That makes you think that more is not better, more may be actually less. Now, I'm sorry to bum you out, but, and I promise I will leave you on a hopeful note, because I'm hopeful. But I'm hopeful with this knowledge that we have work to do. And that the time for incremental change, which is what all of us in hospice and palliative care have been working toward for many years, is past. The demographic waves are coming our way. Our ankles are already wet. And in fact, for those of us who've been working for, for myself, 3 decades of trying to do this, September was a sobering month. Because if there's one place where we have put most of our efforts, it's in cancer care through the end of life. But 2 studies or reports came out in September that make it seem that even here, the results have been, well, insufficient. One from the Dartmouth Institute, they just updated a ongoing report on cancer care near the end of life. In September, they looked at the recent data from the last couple of decades, and they said, despite the increased frequency of end-of-life care discussions, cancer care has become more aggressive in general, particularly as we approach the end of life. Previous research has shown that regional supply of health resources such as hospitals, intensive care beds, imaging equipment is one driver of the intensity of care irrespective of patients' particular condition or illness level. And they conclude in a sort of staid fashion, regardless of the cause, the findings presented here in this brief suggest that there is more work to be done to ensure that the wishes of cancer patients facing the end of lives are elicited, understood, and honored. What they found was that while more people are getting cancer care, are getting hospice care at the end of life, they're getting it for ever shorter periods of time. While more people are staying out of the hospital, actually the proportion of people in the hospital that are in ICUs remains at about 20% as they die. And while again, the amount of people being able to experience hospice care is higher, the intensivity of care, including chemotherapy during the last 2 weeks of life, hasn't changed a bit. Little bits of progress, but often counterbalanced by other factors. As if this wasn't enough, the Institute of Medicine released a report long under preparation called, and I want to call attention to the title of the Institute of Medicine's report, Delivering High-Quality Cancer Care, Charting a New Course for a System in Crisis. Folks, for the Institute of Medicine to put the word crisis in the title of a report should set people's hair on fire. They don't use this easily. In fact, after 3 decades of focusing not just on care for people through the end of life and trying to make the quality of the end of life better, but particularly in cancer care, one would have to say that cancer care has been sort of the canary in the coal mine. Folks, the canary has died. In order to really acknowledge how much work we have ahead, we gotta grieve the fact that we haven't succeeded really, even though we've succeeded in small ways. In fact, that Institute of Medicine's reports points to some trends that are really concerning. And just in cancer care, the population of people is aging. We talked about that. The population of people with cancer is growing with it because cancer is in large part a disease of older people. The workforce issues are challenging. There's not enough palliative care doctors to go around, and we don't think there is going to be in the next 2 decades. But also there's a huge nursing shortage, nurses' aid shortage, and on and on. We're relying more and more on family caregivers. We're shifting the burden of care from professionals who are paid to families, and we're shifting costs increasingly to families. It's still going on even with health reform. And the costs of cancer care, of course, keep growing even as cancer treatments get better. We could go on and on. We have a problem. Now, there are successes. Hospice care is growing. There's now 4,000 hospice programs in the country. We are taking care of more and more people. Something like 40% of people who die receive hospice care. But folks, they're getting it for ever shorter periods of time. And hospice has been working on this for almost 3 decades. We're trying to raise the median lengths of service in hospice care, which have fallen from 23 days to 21 days. The most recent report was 19 days. And yet it's falling further. Since the demise of a famous hospice program in San Diego Hospice, it's fallen even further. The interim report suggested it may now be down to 14 days. This is not end-of-life care anymore. This is brink-of-death care. People aren't experiencing hospice, except for here perhaps, with enough time to make use of what hospice can provide. Now look at this pie graph. Remember that Congress in 1981, when it passed the Hospice Medicare benefits, suggested that we should have access to hospice care for about 6 months, the last 6 months of life. That's 180 days. Look at this pie graph. We're clearly giving cancer care, hospice care for a shorter and shorter period of time. But guess where the regulatory bodies, the Office of the Inspector General of Health and Human Services, is putting its regulatory muscle and your taxpayer dollars to figuring out why the people who live beyond 6 months are still getting hospice care. And they are accusing the hospice programs who have increasing lengths of service, like San Diego Hospice, of tantamount fraud. This is the one area of health care in which if people live longer because of the care that you provide, you're at risk of fraud. And yet I thought people living longer was a good thing, isn't it? So let me just suggest it's time to reboot, because this isn't working. Let's go back to what we know. I mean, really go way back to what we know. Let me start with the nature of illness. Because while we have a disease treatment system, a disease detection and treatment system, what we want is a person-centered care system, right? The fact is that doctors and health administrators are people of good intentions. They're caring, loving people, skilled professionals. But we've been using the wrong lenses to look at the problem. We've been picking, therefore, the wrong tools. We react as a society and as clinicians to people who are seriously ill through the lens of the medical model, looking at disease as being medical, and it is. But while disease is medical, illness is personal, intensely so, for the individual who is ill and for his or her family. This distinction is absolutely critical. If you can understand that there's a distinction between what's medical and what's personal, and understand that illness, of course, entails medical problems, but the nature of illness, the experiential nature of illness is personal, then everything else that I'm going to say will make sense. And perhaps you'll see a way through. Because we've been bringing the wrong tools. Illness is personal not only for the individual, but when any one person gets a serious diagnosis, his or her family experiences the illness. When you can understand that, then you can begin to understand that perhaps, we've been bringing the wrong tools. It's like trying to tighten a screw with a pair of pliers. Your attempts may be earnest, you may put in a lot of energy, but the result is likely to be messy and a little bit unsatisfying. When you begin to understand that it's personal, you can begin to address the needs of the persons you're caring for. Here's a little tool just as an example of what's useful. This is a Get to Know Me poster that we put up in the ICUs at Dartmouth these days. Now this gentleman came in as 0047. He was found down by his crumpled bicycle, and a bicycle helmet that was crushed lay by him. But he had no identification, and he was airlifted to Dartmouth Hitchcock, and we met him in the ICU when the neurosurgeons had said there's really no significant hope that he's going to get better. And believe me, for neurosurgeons to say that, the devastation must be dramatic. We didn't know who he was for a day or so, day and a half, and then his family came, and with the use of this poster, they delivered him from anonymity. We found out that we were caring for a remarkable whole person, and it changed everything about his care. From the nurses' aides, the respiratory therapists, the housekeepers, the residents, interns, fellows, and even the neurosurgeons realized that, wow, this is a remarkable human being. A little tool, but it transformed the care for him and, more importantly, for his family. This is possible to do. I chose the phrase, the best care possible, for this talk, and yes, for a book that I recently published, not to sell the book or because it's clever, but because it's a phrase that's been coming out of my mouth for about 30 years. It's the only thing that I know that everybody in our society really wants. It's a diverse society. Regardless of their age, their diagnosis, the color of their skin, the language that they speak, their religion, everybody wants the best care possible for themselves if they're ill and for their loved ones. So I've used the phrase as sort of an empty vessel into which to pour specific meaning. I found myself saying this again and again, and I started finally just writing it down to teach the students and residents. In meeting you, I want to make sure that you receive the best care possible. In addition to all the treatments for this disease, that includes attending to your symptoms and your sense of well-being. In focusing on your physical health, I don't want to ignore how this illness affects your personal life, your feelings, your hopes, your fears, as well as those of your family. So I've said, I don't know what it is for you, but here's what it is for me. It's at least attending to more than the best treatments. We're going to do that. But we also want to attend to your well-being and your families. In order to do that, I need to know more about the person and his or her family. Now, this is not just my idea or some new agey, woo-woo hospice and palliative care idea. Indeed, the Institute of Medicine, now back in 2001, in a wonderful book called Crossing the Quality Chasm, began to define quality differently. And part of the elements of quality is that it's patient-centered. So what I tell medical students is that, medical science is just biology until it's applied with caring intention in a particular way to the well-being of a person. Then it's medicine. That's the practice of medicine. This is something that now we can use as a conceptual framework for quality. And all of these parameters can be measured and ought to be transparently reported so that institutions and clinicians can continually improve their job, and that those of us who are citizens and consumers can vote with our votes, but also with our dollars, to choose places that have the best measured outcomes. Now, when I teach quality improvement, it's clear that healthcare practice needs to conform to published best practices of our professional associations and the Institute of Medicine and the blue ribbon panels that we look to, and it really should. And those best practice guidelines are based on the evidence base from randomized controlled trials or meta-analyses and the like. And when that's not available, from expert opinion, a consensus guidelines, right? And that's good, and that gets you pretty far down the road as a clinician or as a researcher or as an administrator of assessing quality. But you know as well as I do that one size doesn't fit all. In order to really deliver on quality, those best practice guidelines have to be translated and applied specifically in highly personalized ways to the person living with illness. Right? It has to be consistent with the values, preferences, and priorities of the person who is ill, responsive to their particular needs and those of their family. This, by the way, is my dad, Ira Byock. Some of you will have read his story. It opens the book called Dying Well. I have my dad up there for two reasons, mainly. First, if he's sitting there behind my shoulder, I got to be telling you the truth. At least I believe it, what I'm saying. But the other thing is, again, to reinforce that we're all in this together. That at the end of the day, we're all just trying to give the best care to the people we love and care for. And that we become expert one person at a time. In fact, the best care is possible, but it takes preparation. And that's a challenge because, as you know it as well as I do, in America, if you ask somebody about, well, what would you like when you're dying? They're going to say, I don't want to think about it. Thank you very much. Can we talk about something else? How about those Cardinals? I mean, whatever, right? In fact, in America, it's always too soon to talk about these topics until it's too late. So often, I'm having these conversations for the first time with people in ICUs who couldn't imagine that their father would ever become so seriously ill. Dad's 79 and has, heart disease and renal insufficiency, but okay. I'm not making fun. It's hard. But we got to have the conversation. Ellen Goodman, syndicated columnist, has started the Conversation Project. In full disclosure, I'm on her unpaid advisory board. Ellen will be in Portland in 2 days to talk about it there. This is a remarkable project that begins to normalize and begins to infuse into just normal conversations or normal family dynamics the conversation about what you would want, what you wouldn't want. This website has lots of resources for free to help families sort through these conversations. Another one that I really like, another website that I like is called everplans.com. And they've put up numbers of resources for planning into the distant future, for planning for legal and financial matters, as well as these healthcare decision matters, but also planning for just in time. If somebody you love just died suddenly, what do you do now? Well, there's a section for that. There's a section for funeral planning. It's just a brilliant little tool and resource pool, and it's free. This needs to be normalized. Now, many of the doctors that I work with who are caring, loving, competent, committed people hate advance directives. Doctors tend to fear these things. They worry. It's like, they have bad dreams about attorneys stalking their house at night, the undead attorneys coming to them. But I suggest that these things are maligned. Colleagues say to me, Ira, they never help me. They're never specific enough. They're never current enough. I never know what to do with them. These things are misunderstood. They were never intended to be prescriptions or plans of care or do not resuscitate orders or comfort measure only orders. It's not that brittle. They're not that simplistic. What they are in the hands of competent clinicians, first and foremost, are communication tools so that in the office or in a church group, people can have a tool that helps them sort through the salient points of these difficult conversations and decisions in ways that are easily explainable, are written in very simple language, and it helps them begin to categorize and sort through their values, preferences, and priorities, which is a challenge because we've been spending all of our time not thinking about it, actively not thinking about it. So these are really helpful tools in that way. They're advocacy tools to help people take care of themselves through these very difficult times of life. I used to tell people when introducing advance directives, this is a way for you to keep control of your body when you may not be able to speak for yourself. Yeah, it is, but I don't start there anymore. I start by saying this is a way for you to take care of your family at a time when they may be left to struggle about decisions about your treatment and care. And they may be feeling crushed by the burden of those decisions, right? This is a way for you to take care of them. That tends to get more traction. And thirdly, these things are counseling tools. It doesn't matter what the person has said on them, whether they want all treatments at all costs or they want only those treatments to keep them comfortable and allow them to die. It doesn't matter. If I have a document from Joe, and I'm meeting Joe's family in the ER or in the ICU waiting room after Joe's had a stroke and now has a fever and, we're having the trach and peg conversation. Whatever is on that form, I can use to help counsel the family through these very difficult times and discussions and decisions. Whatever it's said. Because I don't come with an agenda. None of us come with an agenda. Our palliative care team doesn't come with an agenda that less treatment is better. Not our role, not what we do. We want to determine with the person or his or her family what the best care is for that person at this point in time, and then iteratively going forward. But at Dartmouth Hitchcock, when I first started talking about these, I got lots of pushback. The oncologist would say, Ira, I can't talk to people about advanced directives. I've just diagnosed pancreatic cancer, for heaven's sakes. I'm trying to build their hope and their trust. And you want me to talk about advanced directives? Yup, I do. Because the only thing worse than talking about them at this point is never talking about them. And it doesn't become easier always when people become sicker. When they come in with a fever and they're neutropenic, that's not a good time to talk about it either. When the disease advances, that's not a good time to talk. In fact, it sometimes becomes harder. You know, Joe, I thought we were going to stay positive. We weren't going to talk like that. Right? So in some families, it becomes disloyal to talk about the possibility of somebody dying. So what I've taught my colleagues, with some success, is to say that, yes, I understand this is an incredibly difficult topic to bring up at this time, but I have a way to do it that really diffuses all of the tension. In order to do this well and consistently, you have to be able, as a physician, in introducing advanced directives, to be able to say two things. The first is, I have an advanced directive. Oops. The first is, we ask this of everyone. This is not about your prognosis or your life expectancy or whether we can cure this tumor. This is our own internal standards. My standards for my practice, our institution standards, is that we ask this of everyone. And the second thing that needs to come out of the doctor's mouth is, I have an advanced directive, and so does everyone in my family. Because we feel that this is part of giving the best care to one another through the very end of life. I do have an advanced directive, and so does every adult in my family. Because I know if I'm in a car accident later today or I have a stroke and I'm unable to speak for myself, my wife, Yvonne, who's back there, and my two daughters are going to struggle with decisions about my treatment and care. I can't stop that. Even without advanced directives, who else would the doctors turn to? But I can first give them clear authority to speak for me, so that no ethics committee or, heaven forbid, court needs to get involved. And secondly, I can give them a sense of what I think I would want, so that perhaps I can lift some of the burden that they're likely to feel from their shoulders and shoulder it myself. My two daughters have advanced directives, and they're perfectly healthy. Now, my daughters are now 30 and 33. This was taken in the spring of 2005. Anybody remember what was happening in the spring of 2005? The Terry Schiavo case was happening, right? During that spring, my daughters, who were, one was in school, one was already out, that they weren't living together. We were, you know, but each of them during the spring, at some point, had a conversation with me, and during the conversation, they said, each of them said, Dad, what would you like for Father's Day this year? I want you to fill out an advance directive. I said, because if, God forbid, tragedy strikes our family, I mean, if one of you were to be seriously ill, it's just about the worst thing I can possibly imagine. The only thing worse than that would be to have some ethics committee or court, or in the wake of the Schiavo thing, heaven forbid, Congress, get involved in our family affairs. You know, if tragedy strikes our family, could we at least keep it in the family? It's not so far-fetched. Quinlan, Cruzan, Schiavo, all healthy young women who ended up framing our conversations and some of the case law in our country about decision-making. The best care, of course, takes competent, caring physicians. Now, it's so interesting, that's where most people start. Well, if the doctors would just, you know, fill in the blank. If they would just get over their reluctance to refer to hospice early enough, certainly true. If they would just get over their opioid phobia and be able to write morphine prescriptions, if they would, you know, just talk to people about advanced direct, whatever it is, all true, but not enough. We need doctors who are skilled in the physiology and the pharmacology of disease treatment, detection and treatment, diagnoses and treatment. We need people, physicians, who are skilled in communication, in shared decision-making. And we need physicians, when somebody is seriously ill, who actually derive satisfaction and enjoy working with seriously ill people. Not all doctors do. And that's okay. Not every doctor needs to be skilled in this, although they all need some basic knowledge and skills. We need doctors in the lab. We need pathologists. We need dermatologists. We need other types of physicians too. But when I have a patient who is seriously ill, when I or someone I love is seriously ill, I want a physician who has all of the knowledge and skills, but also derives satisfaction from working with seriously ill people. Either this is the wrong chart, he says, or, well, let's just hope this is the wrong chart. I don't show this just to entertain. I mean, it's funny, but it's funny because it got into the New Yorker cartoon because it resonates in some way with the social psychology of our country. This is part of the social psychology of the people who become our patients and families. We know that doctors are awkward in having these conversations. Now, folks, I can teach the vast majority of medical students to have these conversations in ways that are reasonably comfortable for them and actually professionally satisfying to them and satisfying for the persons who are their patients. But I can't teach it in a lecture. I can't teach it in a day. I gotta have these students required to be on service with us. I have to have standardized patients, actors who we pay to be patients, who they can practice with video cameras so that they can see in a very private way what they sound like and look like as they're having these conversations in safe, mentored settings where they can learn these skills. I need OSCEs, which are performance-based evaluations, so that medical students know how they're doing, so that we can separate out those who need more work from those who have mastered these skills. Indeed, it's a changing world. The new doctors that we need for the next 10 years, for this third millennium, are going to be different. They're going to need different skills than the things we're teaching in a curriculum that was basically designed in the latter part of the 20th century. We need doctors who can integrate multiple streams of information that is coming just, it's like drinking from a fire hose with the amount of information coming to us day in and day out. We need people who continuously learn on the job and systems that help them with practice-based learning. We need them to understand that this is teamwork and that we need to collaborate in a robust way. We need doctors who understand family systems and family life cycles and social systems as well as healthcare systems. And on and on. We need doctors who can guide and support people and advocate for people through these difficult times of life. Doctors who are skilled in communication, who are aware that in this next phase of our professional careers, everything will be transparent. That's actually a good thing. But it can be intimidating if you weren't trained in those environments to see transparency as a good thing. Now, things have changed dramatically. I mean, when I was growing up, shared decision-making happened when the doctor shared his decisions with you. But these days, we recognize that shared decision-making is the appropriate way to make critical healthcare decisions. We clinicians, we doctors come to the clinical encounter hopefully expert in the science, in the science of diagnostics and treatments. But our patients are already expert in their personal values, preferences, and priorities. It's together that we can work to translate the best medical science and the best patient-level information from the scans and the tests to the best care for people living with serious disease, the illness, right? We can do this. I don't know what the best care is when I first meet a person, even if I understand their age and their genetics and their comorbidities. I need to know who they are. If I see two people in a given clinic who have the same exact age, diagnoses, and comorbidities, the best care for one may be entirely different than the other. That's the nature of practice. But I do know how to find it out. I do know how the process of shared decision-making can help me discern what the best care is for each one. The best care takes teamwork, of course, as well. This is a team sport. In fact, it's embedded into the definition of palliative care. My definition of palliative care, including hospice care, is this. It's interdisciplinary care for persons with life-threatening illness or injury, which addresses physical, emotional, social, and spiritual needs and seeks to improve quality of life for the ill person with his or her family. Interdisciplinary is different than multidisciplinary, although you'll hear those words used interchangeably. Multidisciplinary means that on any given day in the hospital or week or month as outpatients, multiple professionals from different disciplines assess the patient and write his or her recommendations in the chart. Interdisciplinary implies that at some point all of these professionals are in the same room, able to collaborate in a creative way to create a plan of care that is truly responsive to the needs of patients and able to improve the quality of life of people with illness and their caregivers. An interdisciplinary plan of care tends to be more dimensional than a multidisciplinary plan of care. It's like going to the plan of care and putting on the 3D glasses. It's bigger. It's more responsive. This is our interdisciplinary team at Dartmouth, a team that I directed until July, that meets every weekday morning for a crisp hour to run the list of the patients in the hospital we're seeing that day. Those that we've been seeing, those who we know are pending consults, and the outs who are in, the people who we've been following for weeks, but who have bounced into the hospital in the last 24 hours. We have the computer set up to alert us so that we can go by and see how they're doing and provide some continuity and some person-centered care layered on to the medical treatment that they're receiving. We have our own volunteer program called the No One Alone Volunteers. Now, many of you will know of the No One Dies Alone program that was started in Eugene, Oregon, which is a phone tree, first of staff, and now they're using volunteers from the community, trained to make sure that people don't die alone. So if somebody's actively dying, the phone tree is alerted and they can make sure that somebody's just sitting and holding vigil with a person. Wonderful program. At Dartmouth Hitchcock, our palliative care program doesn't require people to be dying to get our service. They just have to be mortal and seriously ill. So we created a volunteer program, screened, trained, supervised volunteers who are there to improve the quality of life of seriously ill people who end up in the hospital. I've given them 3 charges to address the comorbid factors of isolation, loneliness, and boredom, which can erode the quality of life of seriously ill people who end up in the hospital. I've given them a license to love. You know, they get that with, we play pomp and circumstances at the last training. We give them a diploma, and I give them a license to love. You know, it's okay. It's wholesome. It starts as simply in the mornings with going around and for those patients in the hospital who can read and have interest, offering them a newspaper. It's that simple. It connects them to the community. It gives them a sense that life is ongoing. It helps for boredom. It's even good for constipation. I mean, it is. So it's possible. We could talk more, but we got to move on. The best care takes integrating what we know in hospice and palliative care into disease treatment, into mainstream care, and it can be done. These days, we're laden still with this either-or model under Medicare. You folks aren't because you're free from Medicare in the hospice program here because of extraordinary community support. But most hospice programs are still dealing with this either-or model. So before hospice, you can have all the treatments you want at all costs or until there's absolutely nothing left to offer. And then, if you're ready to give up, you can meet these hospice people, and bless their hearts, you're going to love them. But it requires giving up treatment for your disease in order to get this comprehensive, person-centered, family-centered service called hospice care. Now, I want you to just notice that this either-or model, that bright line, is not determined by some principle of medical therapeutics or by some principle of medical ethics. It was determined by Congress, which said in 1981 and 82, as this Medicare legislation was wending its way through Congress, that if this new package of services called hospice care is going to be offered, we have to have people give up some of their Part A benefits because it would be too expensive to do them both together. Now, that was a reasonable assumption at the time. I didn't object to it, and I was a practicing doc at the time. But we now know that the assumption, reasonable as it was wrong. Because we now know that if you force people to give up treatment for their disease in order to get this comprehensive range of services called hospice care, they will come to it very, very, very late. They don't want to give up even the potential of future treatments for disease. That's part of why we're backed into this ever diminishing length of service called hospice these days. It's not necessary. It turns out that if you introduce hospice earlier, everybody is happier. And the costs don't go up, they actually go down. Look at all of the services that we can provide under palliative care, and a hospice program freed of the Medicare benefit constrictions could provide as well. Lots of goals of care clarification, shared decision-making, assessments of patients' well-being, assessments of families' needs, of family support. Spiritual assessments, because when there's nothing like facing dying to bring out the spiritual core of the human condition. The prevention of crises, because for some of these people we're caring for, think of patients you may be caring for with congestive heart failure, who have ejection fractions 20% or less. It's not a matter of if they're going to have shortness of breath and a crisis. It's sort of just a matter of when. So you have to prevent it. When they approached Edith's cardiologist and told him about the idea, he said, "That's unheard of. I won't do that." They called me and asked me to please give the cardiologist a call. Initially, he said the same to me. "Are you kidding? She's not dying. She just has shock myocardial syndrome." So I asked him the surprise question. I said, "Would you be surprised if Edith were to die within the next 6 months?" He said, "No." I said, "How about the next 3 months? Would you be shocked if she were to die in the next even few weeks?" He said, "No, not really." I said, "Well, look, she doesn't lose anything at this point by going into hospice care. Why don't we give it a try? Her performance is declining. Her performance status is awful. Her serum albumin was less than 2, a sign of malnutrition. I explained that the family was willing to be with her or hire nurses' aides if they can't be with her at night. The hospice program would send skilled nurses to weigh her, to take her blood pressure, to help you adjust her diuretic dose. There'd be special attention to her breathing and her blow bottles, and the hospice would send a physical therapist out to the home once or twice a week and teach her, but also the aides and her family to help her do her physical therapy, and we'll see what happens." And he said, "Oh, okay." He reluctantly agreed. Well, it all worked great. Once at home, Edith's mood improved. She started eating. She worked out with the physical therapist and the nurse's aide. She did her exercises faithfully. Her improvement was slow, but gradual and gradually a little quicker. Her stunned myocardial syndrome gradually resolved. Her swelling subsided. Her depression lifted. Within 3 weeks, she was up and around with a walker. Within 5 weeks, she was feeling better enough that they graduated her from hospice care. Here's a picture of Edith at a family gathering, a wedding that I was with and was able to dance with her at the affair about 8 months after surgery. Here she is in the summer of 2000 at another family affair. This is actually a detail from a larger picture with Edith being, feted by her children, her grandchildren, and her great-grandchildren. And here, just last September, is Edith with her great-grandchildren. I want to say to all of you in hospice care, thank you for giving me my Edith back. Now, the odd thing about this is that the hospice program isn't sure what to do about this, right? This is a challenge for hospice nationally because people on hospice are supposed to die, but sometimes they get better, and folks, that's a good thing. Alleviation of symptoms and suffering are our first priorities, but they're not our ultimate goals. Now, that may sound strange until I remind you that, remember, illness is fundamentally personal. It's only partly medical. So there are achievable, valued goals that some people at least identify during this difficult period of time we call dying. An opportunity to share the bad news that they've just heard, to share sad feelings, to share their fears and their hopes. An opportunity to complete their business and legal affairs, to turn over the projects that would otherwise be left undone, to finally tell their family about the computer passwords so that they can get into the accounts, right? An opportunity to complete relationships. Not that relationships have to all end, but they be complete like a circle is complete, that it's unbroken, that there's nothing critically important left unsaid. An opportunity to resolve previously strained relationships. Perhaps between a husband and wife who were married for 20 years, but that ended in a bitter divorce now 12 years ago. Perhaps between a father and son who have fought over the years. Or former business partners or brothers or sisters who fought like, crazy 10 years ago and haven't spoken. When one or the other is facing the end of life, not always, but pretty often, the bonds that connect them begin to look stronger than the infractions and the anger that divides them. A chance to review one's life, to tell one's stories, to leave a legacy to families. A chance to explore those realms of meaning and connection to something larger than ourselves, which will endure into an open-ended future. It may be religious if you believe in God, but it may be just going back into nature. Having ashes scattered on the ocean, or being buried on a plot of land that's been in the family for years. Connection to family that will live on for generations to come. For years, I've been teaching the 4 things. I didn't make them up, and they're not things. They're just 11 words. Please forgive me. I forgive you. thank you, I love you. Please forgive me and I forgive you are things that many people value saying. There hasn't been a perfect relationship in the history of the planet. Even the most close and loving relationships can be marked by hurt feelings, misunderstandings, and sometimes real transgressions. Please forgive me, I forgive you. Thank you and I love you is a bit like stating the obvious, but boy, is it of value to state it here for both sides. I don't tell people, you know, you need to say this before mom dies. I wonder aloud if they wouldn't be of value for them to say. And I counsel ill people, who else on the planet can say these things to your children in a mother or father's voice? What a gift that would be. Let me give you a sense of this. This is David Plant. Oops, will soon be David Plant. This is from StoryCorps.
And time now for StoryCorps.
I'm an unpaid advisor
Today,
here, too.
A story about reaching the end of life.
David was a patient of mine.
It was recorded as part of StoryCorps' new Legacy Initiative, an effort to collect interviews with people who have life-threatening conditions. In 2010, David Plant was diagnosed with skin cancer, which has since metastasized in other parts of his body. David recently sat down with his stepson to talk about his death.
I'm David Plant. I'm almost 81 years old, and I'm about to speak to my son, Frank.
My name's Frank Lilly. Difference in names is because David is my stepfather, but I certainly consider him my father. So you first met me when I was about 9 or 10 years old when you married my mother, and I'm just wondering what your impressions were of me at the time.
You were a good-looking, athletic guy, but you were in the unhappy situation of broken family.
I didn't have a lot of people to look up to at that time, or a lot of friends, really. And so you became one of those very rapidly, and that meant a lot to me. You know, I was thinking the other day how much I've looked up to you and used you as an example. And I realized that's what I'm doing right now again. I'm watching all of this, and I'm trying to learn. How are you handling all this?
Well, I think in a year from now I won't be here. I'm not anxious about whether there's a heaven or whether there's music or clouds or whatever. I'm more anxious about the end-of-life journey. I want it to be quiet, contemplative, and calm. For me, dying, it's very enlightening and certainly rewarding. Look at the opportunity to talk, for example. It's just incredible. We would coast around having a drink before dinner, never get down to anything that was serious.
That's exactly right.
But I don't regard this as the terminal point of these conversations, because I'm confident we're going to talk again and again.
What would you like to see after you go? I mean, what is your legacy?
I would just like people to believe that humility, listening to the other person and trying to understand the other person, and forgiving are important.
You know, to be honest, I don't feel like I have to forgive you for anything. I'm really just very grateful, and I love you, and I thank you.
Thank you.
This is scalable. I mean, I don't have the time to tell you the fullness of David's story, but he died well on his own terms. Nothing left undone, nothing left unsaid. He used lots of medical care. His care was expensive. He had 3 episodes of radiosurgery for brain mets because it was clearly worth the quality of life was worth sustaining, and the risks versus the potential risks and burdens were clearly outweighed by the benefits. What's interesting here is that I can scale this up. I know how to do this. It wasn't just luck. But to do so, we need a functional health system. And that, you know, right now we're dealing with a dystopia that makes it very difficult to even see what a functional health system would look like. Let me give you two sobering examples and then really turn to hopeful processes. One is this one. I don't know, those of you in the field may have seen this. It was sent to me by at least 10 people. This is a May 2012 cover of New York Magazine in which the essayist Michael Wolff depicts his mother's descent into a living hell of dementia. And as you can see, it's titled, "Mom, I Love You, Please Die." You I wish you were dead, and I think you would too. As he tells this story about her descent into dementia, he opines that our society will eventually be forced to embrace the active hastening of our parents' deaths. He describes how he and his adult siblings, his brothers and sisters, struggled with a cardiologist's recommendation that their demented mother undergo replacement of her calcific aortic valve. Ultimately, despite his mother, who had an advance directive and had been a very strong union organizing person, she was a very strong lady, who had, and these are quotes from his article, volubly and in writing expressed her wish to avoid any aggressive treatments, her children overrode her and agreed to surgery. Her heart was repaired, while her mind became rapidly ever more muddled. Now, as he was writing the article, she is suffering and her family is struggling both emotionally and financially. Now, just in context, aortic valve surgery may be a good idea for exceptionally healthy octogenarians who fully understand and accept the risks of the surgery. However, in the case of Wolf's 84-year-old demented mother, who had volubly and in writing requested none of this, it seems that the surgery represents medical battery. Wolf and his siblings can be forgiven for their decision. It was clearly made out of love for their mother and the grieving for her loss. More troubling, the doctors who recommended the procedure, who performed the surgery against the patient's wishes, were never censured. They and the hospital in which it was performed were paid well for the procedure. And in reading through the emails or the comments on the New York Magazine blog, the vast majority of the over 400 entries applaud Wolf, his courage, and agree with him that at some point we really will need to embrace not just assisted suicide, but euthanasia for our loved ones. Paying for bad care is enabling behavior. My question is, why do we pay for bad care? This care is outside of the guidelines that any surgical society would promulgate for a calcific aortic valve replacement. Why are we doing this? And it's not just disadvantaged people who are thrown into the maw of the healthcare system. You may recognize this guy. In the latter pages of Walter Isaacson's book about Steve Jobs is the following section. These are quotes. The following Saturday afternoon, Jobs allowed his wife, Powell, to convene a meeting of his doctors. He realized that he was facing the type of problem that he never permitted at Apple. His treatment was fragmented rather than integrated. Each of his myriad maladies was being treated by different specialists, but they were not being coordinated in a cohesive fashion. Quote, one of the big issues in the healthcare industry is a lack of caseworkers or advocates that are the quarterback of each team, Powell said. This was particularly true at Stanford, where nobody seemed to be in charge of figuring out how nutrition was related to pain care and oncology. So Powell asked the various Stanford specialists to come to their home for a meeting. And that meeting resulted in a new regimen for dealing with pain and coordinating the other treatments. They had to do this themselves in their own home because nobody in this remarkable health system was doing it for them. Now, folks, we know about how to improve health systems these days. There's actually a science of health service delivery and healthcare improvement. Avitas Donabedian, a physician, re-imported the Deming model of CQI from Japan, where the Japanese automakers were using it to effectively compete against American automakers. It was called Kaizen there, right? They brought it back, and he gave us the CQI model, the structure, process, outcome model. He said famously in 1988, we need detailed information about the causal linkages among the structural attributes of the settings in which care occurs, the processes of care, and the outcomes of care. We're still using that basic framework for quality improvement today. But we're dealing with a health financing system that was developed when phones still had dials, and when doctors' offices were the de facto health system in any community. Phones no longer have dials. And we now are dealing with really complicated, complex health systems, but we're still dealing with a fee-for-service environment in which the business model basically is more is better. The more tests, the more treatments you give, the more visits, the more episodes of care, the better things are. We're now starting finally to move. Yes, with the Affordable Care Act, but even if that had never passed, we would be dealing with this because the major payers, the United Healthcares, the Aetnas, the WellPoints, as well as the major insurers and buyers of healthcare like Ford Motor and Delta Airlines, are pushing the healthcare industry towards shared financial risk models, where it's not more is better, it's better is better. Because they're going to measure quality, they're going to give you responsibility for a population to be cared for, and now it really matters. All of that care and coordination that Powell Jobs was talking about now really matters. You know, care managers and case managers are about to get more of the stature that they have always deserved but never gotten. The challenge will be to keep the doctor and patient in the center of this new framework. Now, we know that hospital-based palliative care and hospice care are part of the success, part of the models we need to scale up. We know that they're growing, and that's helpful. We know that it's helpful, and it's growing not just because we improve quality, and we do, but because when we're involved, the costs diminish. This is actual data from Dartmouth-Hitchcock, FY11. Now, I don't have a lot of time to explain this, but before, you see it's split in the middle. That's the day zero when we first touch a patient. This is group-level data on the costs per patient per day of everyone that we touched in FY11. To the left are the costs per patient per day before we saw them, and to the right, after. Look at the bottom, which are the direct costs, meaning that's what it costs the health system to care for these inpatients. The cost per patient per day dropped by about $600 per patient per day after we get involved. And we're not talking people out of anything. It's not our job. We're simply doing shared decision-making, making the best plan of care we can, and monitoring people's symptoms and their well-being. So $600 per patient per day. If you look in the black box, we saw over 6,000 patient days. You can do that math. That's over $3.5 million. Is it any wonder that looking at this data, the CFO and the COO says, we need more of you guys? Hospice care has now been shown to diminish costs to Medicare at whatever length of service is provided. Until now, we thought it was just hospice care only had a sweet spot of somewhere between 30 and 70 days where it actually diminished costs. But it turns out, no, whatever period of time hospice is involved actually saves Medicare money and improves quality. To do this, we need a family. It takes a family. You know that. And I don't mean just family by bloodline or marriage, family by for whom it matters. These days many of us live in atypical families, blended families, same-sex couples and the like. And we need to, start caring for families. I mean, these days, family caregivers are a diagnosis unto themselves. It takes a toll. We can do better than this by not just seeing patients, but seeing patients with their family caregivers. For every Harry that I see, there's almost always a Shirley. Harry may have Parkinson's disease and some prostate cancer and a little memory loss and dementia. He sort of shuffles. And there's Shirley, who's got hypertension and congestive heart failure and a little diabetes and some macular degeneration and some spinal stenosis and osteoporosis. But they fit together really well because they grew together. Now, these days, we don't see Harry or Shirley until Harry falls and breaks a hip or Shirley has a stroke. And then it's treatment at all costs, no holds barred. But we could have lengthened their life, improved their survival, and improved their quality of life if we had been able to see Harry and Shirley as a community, as a frail elderly couple. We would have assessed them. We would have gotten those darn throw rugs off the floor so Harry wouldn't have fallen. We would have gotten the grab bars on the in the bathroom and the ramp up the stairs and done all of the things that help with their medications and help support them. We would have saved a whole bunch of money in the process. Dwight Eisenhower said, if a problem can't be solved, enlarge it. In seeing that medical problems are only part of the illness experience, we can actually look at improving the quality of life the longevity and satisfaction and richness of life of ill persons and their families. To do so, it's going to take a shift in the way we approach illness, dying, death, caregiving, and grief. We need to grow the rest of the way up. I want to say to all of us, especially those of us who are boomers, you're going to die. Get over it. And let's get on with making the best of it. We've done this before. When we boomers were growing up, we took back the beginning of life. When we were growing up, pregnancy and childbirth were medical events. I was born under general anesthesia, right? But when we were having babies, we boomers took it back. We said that the fact that pregnant women and women in labor need expert medical care does not define these experiences as being primarily medical. They are fundamentally personal for the woman, her family. You know, it was a fight initially. This didn't come initially from doctors and the medical system, though we got on board. Initially, it was citizens and consumers taking it back. There was pressure against the notion of having fathers in delivery rooms. I saw medical journals, articles, and was part of hearing conversations about, well, we can't let fathers in deliveries. They'll fall over. They'll faint. They'll get in the way. It'll be a problem. We took it back. We insisted of better medical care. Prenatal care went from just checking blood pressures and urine for protein to prevent preeclampsia to really talking about peak health and exercise and nutrition and sexuality and Lamaze classes for prepared childbirth and La Leche League classes. And guess what happened? We turned out that the measurable impact of prepared childbirth was better than the outcomes of unprepared oh, you're such softies. Than unprepared childbirth for everybody involved. The measured outcomes, the health outcomes were better. Folks, exactly the same process needs to happen now. Yes, we need to demand ever better medical care, patient-centered medical care, but that's not enough. We need to take this back. We need to integrate illness, caregiving, dying, and grief within the fabric of our full and healthy lives as a community. This is part of human life. Life is a precious gift, but it's a finite gift. These days we're bombarded with calls to give money and to vote for, death with dignity. But human beings have always been dignified. That's not an assertion on my part. It's not some philosophical statement. This is settled social ethics. In 1948, the UN Declaration of Universal Human Rights declared that all members of the human community are inherently dignified. Our job is to help people feel dignified, despite their frailty, their complete physical dependence. People need to be able to see their dignity reflected in the way care is given, in the deepest respect which every interaction takes place. That's the harder job for all of us, not just as clinicians, but as a caring society and culture. We can get there, but it's going to take some courage. It's going to take advocacy and activism. These days, you can't have these conversations with politicians. They don't want to talk about it because they're afraid, on the one hand, of being accused of rationing if they talk about it, and on the other hand, of promoting assisted suicide, so they just stay away from it. And of course, politicians these days don't want to talk to one another. But we can get over this as well, because it turns out even the people that we disagree with most vehemently agree with us on the values of good care, of people making decisions, of being supported in their decisions, of good symptom management, of loving one another. We have a model for it. When natural disasters strike, this is from Hurricane Sandy, just before the 2012 elections, people didn't say, well, who are you voting for before I help you? No, that would be absurd. It's laughable. We spontaneously, reflexively move together to high common ground because we're in this together. A natural disaster focuses us on our commonalities, not on our differences. Even these two guys got together. This is not a bromance that's likely to continue. But it was nice to see them acting responsively in service for the public good. We can do this together, but it will take some political action, as well as lots of citizen consumer action. Let me suggest a few things that public policies can do. We could require adequate staffing and living wages for aide-level workers in nursing homes and long-term care. If somebody wants to preserve the dignity of frail elders, let's make sure there's enough people to answer the bell when a frail elder needs help in getting to the bathroom or is wet and needs to be changed. That we can do, and it would be cost effective. The more people in nursing homes, the less middle-of-the-night transfers to the ER or ED. We can set realistic training standards for physicians and other clinicians, nurses and allied health professionals. I think curriculum parity, at least with the beginning of life, with prenatal care and neonatal care that's taught. And we can eliminate the ridiculous requirement that people have to give up treatment for their disease in order to get state-of-the-art care for their comfort and quality of life called hospice care. We know it doesn't save money. It actually costs more money to enforce this terrible choice. And finally, reflecting on Michael Wolff's mother and similar circumstances, we could at least require documentation of true shared decision-making and maybe even a formal palliative care consult before paying for the procedure. I'm not against these procedures. I actually love state-of-the-art aggressive medical treatments to save lives. I just want to make sure that it's in the person's well-being, in their interests, and consistent with their values, preferences, and priorities, and not result of some coercion that is being, if not economically driven, at least economically supported. Lastly, and I'm sorry this has gone so long, but let me just end with the obvious. It takes love. You know, the best of human caring has always been described by the phrase tender, loving care. Yeah, it takes humor too from time to time. We know how to do this. It's been, it's there in the literature. Francis Peabody famously said in 1927, one of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. Now, Francis Peabody was by description, a crusty, irritable surgeon at Mass General. But he knew this. Engelbert Dunphy, who became chief of surgery at UCSF, one of the really premier surgeons, American surgeons of the 21st century, wrote, Francis Peabody's dictum permeated our student days at Harvard. We learned that the practice of medicine is cold and abrasive unless tempered by love. This is core. Indeed, remember Avitas Donabedian, who gave us CQI in healthcare. When Donabedian was facing the end of his life, he had prostate cancer. He was interviewed by Fitzhugh Mullen for Health Affairs, and he said, systems awareness and systems design are important for health professionals, but they are not enough. They are enabling mechanisms. It is the ethical dimension of individuals that is essential to a system's success. Ultimately, he said, the secret of quality is love. You have to love your patient. You have to love your profession. He added, you have to love your God. If you have love, you can then work backward to monitor and improve the system. So that's the challenge ahead. You know, creation is not merely some biblical abstract or construct. In fact, the astrophysicists remind us that creation is ongoing. The universe is quite literally expanding. Certainly the reformation of our society and our culture is an ever ongoing process, and we are not merely victims or passive journeyers on this trip. We are active participants. We have an obligation, a responsibility, and an opportunity to put the values that we bring to the care that we provide into the mix, to tell stories, to expand people's awareness of what's achievable and to help them achieve it. We can go forward to create the society, not just the healthcare system, but the society that we want to leave behind for our children and grandchildren. This is our great challenge, ladies and gentlemen. This is our remarkable opportunity. Thank you all for the work that you do day in and day out, and thank you so much for allowing me to share my thoughts this morning. Thank you. Thank you very much. Thank you very much. Thank you all. Thank you. Thank you all very much. To life. Thanks. You're a remarkable group. Thank you.